Hi everyone. We'll talk about the upper cervical spine traumas, so i.e. occipital condyle, C1, C2 fracture. So our objective will discuss about AO dislocation, occipital condyle fracture, C1 fracture, odontoid fracture, hangman fracture, atlantoaxial dislocation. So I want you to get the idea how to think about it, preoperative preparation, intraoperative and postoperative care for this patient. So you have to keep in mind there's general factors and local factor for the fractures. For general factor, you look for the patient as a whole. So the age is important key. Extreme of ages, infant, there's special consideration, elderly, special consideration, pre-existing disease, ankylosing spondylitis, rheumatoid, connective issues, or the Down syndrome, because these patients they have special things. They are immunosuppressed, they are other anomaly, they have cervical thoracic disease. So you need to keep it in mind. The comorbidities, COPD, cardiac, renal, other injury, chest injury, which might affect your decision putting the patient in halo vest, other spinal injury, traumatic brain injury, expertise. So even if you're here, you need to make sure you have the right team to do this kind of cases. Anesthesia familiar with this kind of cases. ICU able to take care of the patient post-operative, good neurophysiologist, and equipment are table, the setup, instrumentation, and so on and so forth. Local factor. You look for bone anatomy if there's any assimilation to C1 and occipital condyle, failure information, clipper file, skull defect, because that will help you and guide you for decision making of type of construct you'll use. Vascular anatomy, vertebral artery, is it apparent course, internal carotid, the kissing, for example, between C1 lateral musculus, bica, extradural. During this section, if you injure it, you might end up lateral syndrome. If there's this section of vertebral artery due to injury, the patient anticoagulated, that will help you and guide you for surgical intervention versus conservative management. Pattern of injury, looking for any angulation, displacement, ligamental status, neurological status of the patient. Is it due to ingoing compression or mechanical compression? So that will time your intervention and type of intervention with or without decompression. Injury to surrounding structure, level above and below, cervical spine, skull fracture, pre-existing focal kyphosis. So after all this factor, you will define your goals. Each patient is unique. Study the images very well. Look the patient as a whole. Review literature, and you have to plan A, B, C if you're stuck. So you have a clear plan. What's your tools? Cervical collar, halo vest, and sometimes you just in pediatric, for example, but still inside fusion with external mobilization. You should be able familiar to use and when to use clamps, wire, cables, hooks, occipital blade, condyle screws, C1 lateral mass screws, C2 bars, pedicle, laminar, transverticular, subaxial lateral mass pedicle screws, the entry point, and all this, it's hand-on. See more cases, get familiar. And ACDF for C2, C3, sometimes you need them, and you're familiar with the transoral lithophryngal approach because sometimes indicated for decompression, bone graft, autograft, allograft cages, all these tools, you need them for this kind of cases. So you have your general factor, local factor, you have your clear plan, then when you start these cases, make sure that you get involved, fully engage with this case. This patient needs fiber optic intubation. You have IV access, venous access, STIVA pressure. You need to do MABs and SSEPs before and after sending the patient. You have the right setup, Jackson table, radial lucent head clamps, horseshoe for an infant or pediatric, Mayfield. I like to have the screen of vital sign because a heat fluctuation of a blood pressure map during the surgery. So maybe you need to make sure you're on top of everything. Or if you like to use them, fluoroscopy, microscope, ICU bus operative, and halo vest. You should have it all the time in case of disaster intraoperative. So we'll start with air dislocation. We see them nowadays more frequent because improvement health systems, so you pick them early on. So there's different way of measurement and discovering AO dislocation. You can use the bubble ratio, the X line, dense basion distant, so dense axis distant, condylar distant, and there's a classification. It could be anterior displacement, posterior displacement, or vertical. For example, this patient, you can see the occipital condyle distant. It's more than 4 because more than 4, it's abnormal for pediatric. More than 2, it's abnormal for adults. So this is, it's almost 7, and also Bayesian dense distant, it should be less than 10 millimeter, but in this patient, it's over that. So it's obvious there's an injury. of AO dislocation. For this patient, you need to put them in halo vest preoperative, and also during positioning on halo vest, you do baseline before and after turning, and keep them in halo vest. And you can take the posterior jacket, do X-ray. You're happy about the alignment, then you do occiput C1, C2 fusion. So almost all of this is surgical disease. Next, occipital condyle fracture. It's not surgical disease. There are lots of classification exist, but I like this one. Type 1, if it is fracture non-displaced, it's a stable, just a collar. If it's displaced, look for ligament. Ligament intact, just a collar. Ligament not intact, then you look for other injury. Usually you have craniocervical instability, so you'll end up with surgery. So always look for associated injury or any cranial nerve deficit, for example, hypoglossal, because it's not far from hypoglossal canal. C1 fracture. So, there's a classification, everyone know about it, anterior arch, posterior arch, lateral mass, Jefferson fracture. But you need to answer two questions. Is it isolated fracture and the transverse ligament stat? If it's isolated and intact, this is just a collar. If it's not, then you will look for other associated injury, and based on that, you will address. So one of the options of treatment, you can do C1 osteosynthesis, which is the nice about this one, you will preserve the motion between C1 and C2. Identified fracture, the classification. So type 1, it's just a stable fracture of the collar, but you need to look for any associated instability from the occipital atlantar instability, so treatment will be different. Type 2 fracture. The trick about this fracture, it's an area with this poor blood supply. So if the patient above age of 40, there's significant displacement, there's angulation, high chance of non-union, so you'll go more towards surgical intervention and instead of conservative from Helivis. So for surgical intervention, it can be posterior atlantic axial arthrodesis or the thread screws. There's pros and cons for both of them. For type 3, it's a non-surgical disease due to collar or Helivis, and you can see it from the table fusion rate for type 2 with the collar 50% versus posterior fusion 93, and type 3 collar or Helivis, it's all above 90, so they fuse really nicely. For elderly, it's a different entity, and a lot of debate in literature. You treat them with the collar, treat them with Helivis surgically, because there's pros and cons for each of them, and it's outside the scope. Okay. Bilateral fracture of the pars interarticularis, so hangman fracture. There's a lot of classification exists, so you can memorize whatever you like, but you need to keep in mind, if you see this kind of fracture, look for angulation, displacement, status of a C2, C3 disc, the facet capsule status, and ALL, PLL status. And based on that, you will decide what kind of intervention. For example, this patient has pars fracture, but there's no angulation, no displacement. We check the MRI about the disc, it's normal, the capsule also normal, ligaments all intact. So this is just a stable fracture treatment with a collar, and they heal amazing. But if the patient has severe angulation or the disruption of the disc space, of this displacement more than 50%, or we can maintain the alignment with external mobilization of the failed initial treatment, then you would go for surgical intervention. Type of surgery, C1, C2 fusion with different wave screws. But if there's disruption of C2, C3, you need to go a level below C3 lateral mass screws. And one of the other options, you can go ACDF C2, C3 to maintain range of motion. Atlantoaxial rotator subluxation, its entity we see it mainly in pediatric. It's usually after minor trauma. The key for this kind of fracture, you need to pick them early, because late presentation treatment is more towards surgery. So when they come early with rock carbon hinge position, you need to reduce them as soon as possible and put them in a collar for a couple of weeks to maintain the position. But if they present late, for example, this patient, she present 9 weeks after the minor trauma, but she moved from subluxation to fixation. So for this one, you need to reduce them. You will try with the halter traction, the halo, but they will fail. If more than 4 weeks, most of the time they will end up with surgery. So you go of this atlantoaxial subluxation, relieve the pain, correct the deformity, and maintain front range of motion. So for this patient, I need to reduce them surgically with a C1, C2. So you put C1, C2, reduce the fracture surgically, and keep them in the collar till they fuse. But in pediatric, they do really well because they will compensate with the subaxial subaxial joint, so they will have some range of motion. And that's it for the day. Good luck.